Hello everyone. So in this topic we will talk about a very important group of drug called local anesthetic, which is the main drug which we use in regional anesthesia. So what exactly is local anesthetic? What is the definition of local anesthetic? Local anesthetic are drugs which stops the transmission of impulse through a nerve fiber. And when the impulse transmission through a nerve fiber is stopped, it will stop the sensory, autonomic and motor transmission of that nerve fiber. And the area supplied by that nerve fiber will be anesthetized. And this will produce something called regional anesthesia. So local anesthetic are drugs. I will write throughout my lecture local anesthetic as LAs. Okay, so local anesthetics are drugs which block the conduction of impulse along a nerve fiber. So it blocks the conduction of impulse along a nerve fiber. So what will happen? It will stop sensory, motor and autonomic transmission. It will stop sensory, motor and autonomic transmission, and this will produce something called regional anesthesia in the area supplied by that nerve fiber. Okay. So if I say this is the nerve fiber, to block the conduction of impulse along this nerve fiber, we deposit the local anesthetic around it, right? Locally. We never give local anesthetic systemically. We deposit it locally. And what does local anesthetic do? Local anesthetic stops the transmission of this nerve impulse. So what happened? The area supplied by this nerve fiber gets anesthetized. Okay. Now, how are nerve fibers arranged? Nerve fibers are arranged in bundles and they are arranged in 3 layers in bundles. So let's say I'm saying that nerve fibers, they are arranged in bundles in 3 layers. Okay. And one bundle of nerve fiber, it's called fascicles and it is arranged in group of fascicles. So one bundle is called fascicles. So they are bundled, nerves are bundled in fascicles. So what is fascicle? Fascicle is group of nerve fiber. Fascicle is group of nerve fiber. And nerves are bundled in group of fascicles. One individual nerve, it is covered by something called endoneurium. Endoneurium. Between the fascicles, we have the loose tissue. This is called perineurium. Perineurium. And the fascicles are again covered with something called epineurium. Epineurium. So they are arranged in 3 layers. And above this epineurium, we have something called myelin sheath. We have something called myelin sheath. Now this myelin sheath, some nerves are myelinated, some are not unmyelinated. If the nerve has myelin sheath and if the nerve is in, let's say, peripheral nervous system, the myelin sheath is formed by Schwann cells. And if it is in central nervous system, it is oligodendrocytes which forms the myelin sheath. So myelinated nerves, they are better, if the nerve fiber is myelinated, they are electrically better insulated and the transmission of the nerve impulse along them takes place in a better way. So when a nerve fiber is, let's say this is the nerve fiber, it is thoroughly covered by myelin sheath. Now myelin sheaths are interrupted at let's say regular interval. They are interrupted at regular interval. This regular interval is called nodes of Ranvier. Nodes of Ranvier. And this is again very important for the nerve transmission, right? So myelin sheath also will make the conduction of nerve impulse fast, and presence of nodes of Ranvier is essential for a fast transmission of impulse. Okay. This is how the nerve fibers are bundled. Now, nerve fibers are of different types right? And there are different types. They are divided according to myelinated, unmyelinated, the diameter, the area which they supply, the type of nerve fiber. So let us see how the nerve fibers are classified. So nerve fibers, types, okay, then their diameter, then their myelination or unmyelination, then what exactly they carry, right? Impulse carried by them, and the function, right? So nerve fibers are divided into nerves are divided into three type: A, right? A, B, and C. Okay. Now C fibers have smallest diameter, 0.3 to 1.3 microns, and they are the only unmyelinated nerve fibers, right? Now, what does C fiber carry? They carry two type of impulses. They are postganglionic sympathetic fibers, and they are afferent to the sensory nerve. Some of the C fibers are afferent to the sensory nerve, afferent nerve fibers of the sensory nerve. And what exactly is the function of the C fibers? Two things. They autonomic function and they carry pain. Okay, slow pain. Okay, C fibers. Then B fibers. B fibers, the diameter is less than 3 microns, and they are myelinated. Now, above this, all the nerve fibers are myelinated, and B fibers are your autonomic. They carry the autonomic. They do the autonomic transmission. They are mostly preganglionic autonomic nerve fibers. Okay. Now comes A fiber, which are of four types: A delta, gamma, beta, and alpha. Now A delta is thinnest among all these, and their diameter is 1 to 4 micron, myelinated. They are afferent to sensory nerves, and they carry temperature, pain, and touch. A gamma, they are efferent to the muscle spindle. They are 3 to 6 sizes 3 to 6 diameter, myelinated, and efferent to the muscle spindle. And they are responsible for maintaining the tone of the muscles. Okay. And then we have A beta, 6 to 22 micron in the diameter, myelinated, and they are afferent and efferent to the muscle and the joints. And they mostly proprioception, pressure. These are the function of these nerve fibers. Now A alpha, 6 to 22 micron is the diameter, myelinated, again afferent to the muscle and your joints. They are mostly the skeletal muscle fibers, the motor fibers, and their function is the motor function, to carry out the motor function. They are mostly carrying out the efferent motor function. Okay. Now, they are the different types of nerve fibers. Now, blocking of the nerve fibers depends upon two things. It depends upon the potency of the drug, which we will discuss. We will discuss different type of local anesthetic, and it depends upon the type of the nerve fiber. See, every local anesthetic, whichever we deposit, the local anesthetic which we deposit, okay, every local anesthetic would need a minimum concentration to block the nerve fiber. So, local anesthetic would need minimum concentration to block a nerve fiber. Now, this minimum concentration depends upon the potency. What is the potency of this local anesthetic? Which would depend upon the lipid solubility, which we will discuss further. And it will also depend upon the type of nerve fiber we want to block. Some nerve fibers, few sodium channel block, their transmission stops. They are very sensitive to local anesthetic. Some nerve fibers, they need more sodium channel to get blocked. Then the blockage of the transmission will happen. So they are a bit resistant to nerve fiber. Now, which of the nerve fiber is most sensitive? Now, this is, let's say, this is something which is controversial. And if I take you to the old school of thought, where everything was black and white, they used to say lesser diameter will get blocked first, unmyelinated will get blocked first, right? If this was the case, C fibers would get blocked first, then B fibers, and then A fibers. But what the clinically we see and what the latest research say, this is not the fact, this is not the truth. It depends upon a lot of things, right? What now we see that some books write that A fibers are blocked. A fibers need lesser concentration of local anesthetic to block them. So A fibers are most sensitive, then B fibers, then C fibers. The opposite, what was the old school of thought. Some books also write that B fibers are blocked first and then your C equal to A delta, then A gamma, A beta and A alpha. This is the sequence of the sensitivity. Now, this is what is called differential block. Differential block means, differential blockade means, what do I mean by differential blockade? Differential blockade I means differential sensitivity of the nerve fiber to local anesthetic. Different sensitivity of nerve fiber to local anesthetic, okay. And if I tell you, if it is only on the diameter, it would be CBA. If it is only on myelination, it would be CBA. But that is not the case. Okay. Today, a lot of different things are written. They say A fibers are blocked first. Some books say A fibers. Miller anesthesia says A fiber is blocked first, then B, and then C. In A, it depends upon the diameter. That is, the A delta will be blocked first, then A gamma, then A beta, and then A alpha, and then B fibers, and then C fibers. Okay. Now, the Stolting, the textbook for pharmacology of anesthesia, they write that B fibers are blocked first, and then your C equal to A delta, and then A gamma, and then A beta, and then A alpha. Right? So one book write this and other book write this. Okay. What we clinically see? We clinically see, to some extent, it depends upon the arrangement of the nerve fibers. In peripheral nerve block, the sequence of the block is a bit different than compared to central neuraxial blockade. So it depends upon the arrangement of the nerve fiber in the nerve also, in the bigger nerve group also. It depends upon how the nerve fibers are arranged. It depends upon their relative sensitivity to the nerve fibers also. So it depends, it's a bit complicated, depends on a lot of things. If I talk about differential blockade, in terms of sensation, then when we see the temperature sensation goes first, then followed by your pain, then followed by your touch, then followed by your proprioception in sensory, right? So this is how the sequence of the let's say sensitivity, sequence of the block we get. So whenever we put a block, since temperature goes first, we always first check whether the temperature sensation of the patient has gone or not. Then we go for pain and then maybe touch and the proprioception. Okay. Okay. So now let us see the mode of action of local anesthetic. Very important, mode of action of local anesthetic. I told you, local anesthetic block the transmission of impulse over a nerve fiber. But where does it actually act to block this transmission? What is the molecular level of the action? Now, if you see that on the nerve fiber, on the membrane of the nerve fiber, there are number of voltage gated channel, and one very important voltage gated channel is your sodium channel. Now, sodium channel is responsible for generation of the impulse, for transmission of the impulse over the nerve fiber. This sodium channel is responsible for changing the membrane potential from resting membrane potential to action potential, right? Now, local anesthetic blocks this sodium channel. Local anesthetic attaches to this sodium channel and stops the passage of ion across it. So when the passage of ion across the sodium channel is stopped, the transmission of the nerve impulse will be stopped. Because what will happen? The resting membrane potential will not change into action potential, right? And the transmission of the nerve impulse will be stopped. Now, just understand, local anesthetic mostly act on sodium channel and its action is mostly because of the effect on sodium channel. But it can also act on voltage gated potassium channel. It can also act on NMDA channel, right? It can also act on chloride channel. So it can act on multiple channels, the local anesthetic. But the main work is by its action on sodium channel. And vice versa, there are some drugs which can also block the sodium channel, like your tricyclic antidepressant. Tricyclic antidepressant, they have potential to block the sodium channel. Your ketamine, they also have potential to block the sodium channel. But whether they will produce the effect like local anesthetic or not, it is controversial, right? So let us come back on the molecular level of the action of local anesthetic. Local anesthetic blocks the sodium channel. This is the thing we have to remember. Now, how? We deposit the local anesthetic around the nerve fiber. This is the nerve fiber and this is the sodium channel present on the nerve fiber. So we deposit the local anesthetic around the nerve fiber. Okay. Whenever you put a local anesthetic around the nerve fiber, now it is let's say it's a weak base. So local anesthetic, they are chemically weak base. So they get cationated. A proton is attached to it, right? They are in equilibrium in undissociated and dissociated form. They go into equilibrium, right, of undissociated and dissociated form. This undissociated, that is the local anesthetic, undissociated, this is lipophilic, right, and it can cross the membrane of the nerve fiber. This cationated local anesthetic, it is not lipophilic, so it cannot cross the sodium channel, right? Your let's say site where local anesthetic will bind to the sodium channel is not present on the extracellular, let's say extracellular side of the sodium channel. It is present on the intracellular side. This is the extracellular side, this is the intracellular side. So here the local anesthetic binds. It is present on the intracellular side. So local anesthetic has to diffuse along the nerve, let's say nerve membrane of the nerve fiber, and it will diffuse in undissociated form, lipophilic form. And then again it will get protonated, cationated, and then it can go and bind to the sodium channel. So when it binds to the sodium channel will get closed, and the passage of the potassium and the sodium along the sodium channel will not happen. And what will happen? The transmission of, passage of the sodium across the sodium channel will not happen. And what will happen? The impulse transmission will be stopped. So remember, two important things from this point we have studied, that mode of action of local anesthetic, the molecular level, it acts on sodium channel. And the site where the local anesthetic binds to the sodium channel is in the intracellular part. It is in the intracellular part of the sodium channel. Local anesthetic can diffuse through the membrane of the nerve fiber in undissociated form. And when it comes inside the nerve fiber, intracellular side, it again gets ionized, and now the ionized form binds to the sodium channel. And when it binds to the sodium channel, right, at the site where it can bind, what will happen? The sodium channel gets closed, and now the sodium ion cannot cross across the sodium channel. So what will happen? The resting membrane potential will not change to action potential, and the transmission of the impulse will be stopped. Got it? Now this sodium channel in an active nerve fiber is in three states: resting, non-conducting state. This is resting and the sodium channel is closed. Now active conducting stage, in this the sodium channel is open. So in resting stage, sodium channel is closed, and in active stage, the sodium channel is open. And in inactive stage, then from active it comes into inactive state. In this again the sodium channel is closed. Okay, so it is closed in inactive stage. Previously it was thought that local anesthetic can bind to the sodium channel only when it is in active or in inactive stage, either active or in inactive. It cannot bind to the sodium channel in resting state. But now this is not true. Local anesthetic can bind to the sodium channel in any state. Mostly it binds in active or inactive state, right? Mostly the local anesthetic bind to the sodium channel in active or inactive state, but it can also bind to the sodium channel in resting state. Got my point? Okay. Now let us talk, right? How does local anesthetic, let's say, what is the pharmacology and pharmacodynamics of the local anesthetic? So let us talk about the physiochemical properties of local anesthetic. Okay. So what is local anesthetic chemically? Chemically, local anesthetic is lipid soluble aromatic benzene ring. It has a lipid soluble aromatic benzene ring which is connected to a amide group, right? This connection can be via ester or via amide bond, right? Ester bond or amide bond. So depending upon whether the bond between aromatic benzene ring and amide group is ester or amide, local anesthetic can be divided into two broad division: amino ester and amino amide, right? Amino ester and amino amide. So it is two group, ester group and amide group, or amino ester or amino amide group. Okay. So chemically, local anesthetic can be divided into amino ester and amino amide group. So what are the drugs belonging to amino ester and amino amide group? So let us talk about ester group and amide group. Okay. In ester group, we have the first local anesthetic which we got historically was cocaine, and that cocaine was an ester local anesthetic. So first local anesthetic which we got was cocaine. Cocaine, a natural LA. It's a natural LA, right? It is a coca plant extract, and it is an ester local anesthetic. The second local anesthetic which was made after studying the structure of cocaine, man-made, procaine. This is again a ester local anesthetic. Then chloroprocaine, ester local anesthetic, benzocaine and tetracaine, right? These are our main ester local anesthetic. Now in amide group, we have a very important drug, lignocaine or lidocaine, whatever you want to say, right? Lignocaine or lidocaine, one of the most important local anesthetic. Okay. Then mepivacaine, then prilocaine, and then again a very important local anesthetic, bupivacaine, and then levobupivacaine, then ropivacaine, dibucaine, right? These are our amide local anesthetic. Okay. Now, if I just divide them on the basis of their duration of action, then cocaine, procaine and chloroprocaine, these three are short acting. Their duration of action is short. Benzocaine and tetracaine in ester group is long acting, right? And amide, ligno, mepiva and prilocaine, these three are intermediate acting, right, according to duration of action. And bupivacaine, levobupivacaine, your ropivacaine and dibucaine, they are long acting. Okay, this is just a division according to the duration of action. Now, ester local anesthetic, their metabolism is unique. They are hydrolyzed by plasma choline esterase. The same plasma choline esterase which metabolizes your succinylcholine and your mevacurium, the neuromuscular blocker. Plasma cholinesterase, or we call it pseudocholinesterase, or we call it butyryl cholinesterase. So, what I am saying that ester group, it is metabolized, ester group is metabolized by plasma choline esterase. Okay. And amide group, it is metabolized by liver. It is metabolized by hepatic carboxyl esterase by hepatic. In liver, by hepatic carboxy esterase enzyme. Okay. Now, ester group, it is metabolized by plasma cholinesterase, and in turn it produces a byproduct in the name of para-aminobenzoic acid, right? So this para-aminobenzoic acid is a byproduct of plasma cholinesterase metabolism of ester group. And this para-aminobenzoic acid, this can cause immunogenic reaction, that is allergy, immunogenic reaction. So ester local anesthetic has little bit more propensity than amide local anesthetic in causing allergic reaction. Amide local anesthetic totally metabolized by hepatic carboxyl esterase group, right? Now in ester group, cocaine is little exception. Cocaine, in spite being ester, having an ester bond, it is metabolized by liver. So cocaine is also metabolized by liver. Cocaine is also metabolized by liver. Okay. Now let us discuss few important physical properties of our local anesthetic. If you see this table, what are the things which we need to know about the physical properties? We need to know about their pKa. pKa, what do I mean by pKa? I mean by pKa is the dissociation constant. What is the pH at which dissociation happens? Dissociation of local anesthetic happens. Okay, that is called pKa. And what do we understand by this word pKa? See guys, depending upon pKa and depending upon the pH of the area where the local anesthetic is deposited, the dissociation and the undissociation of the local anesthetic depends upon that, right? If pKa and the pH of the area does not match, the local anesthetic will go into dissociated and undissociated form to achieve equilibrium. As near the pKa is to the pH, the dissociation would be less and less. Less dissociation, more lipid solubility. More lipid solubility, faster would be the action. So if I see bupivacaine has pKa 8.1. 8.1, much higher than the pH of the blood, that is 7.4, the normal pH of the blood. So 83% of the bupivacaine would be ionized, which is a bit higher ionization. So the onset of the action would be bit slower, of bupivacaine. Let's talk about lidocaine or lignocaine. The pKa 7.9, which is near the serum pH 7.4. So ionization is much lesser. You are getting my point? Lesser ionization, faster would be the effect. Okay. So on pKa depends the onset of action of the local anesthetic. Okay. Next thing which we need to know about is the lipid solubility. Now on lipid solubility depends the potency of the drug. More the drug is lipid soluble, better is its potency. And how is lipid solubility calculated? So lipid solubility, how it is calculated? It is measured by the partition coefficient, in a hydrophobic solvent, octanol, right? High octanol buffer partition coefficient, more lipid solubility. Okay, more lipid solubility. Now, what is the clinical importance? Clinical importance of higher lipid solubility. Clinical importance is high lipid solubility, high potency, and longer duration of action. High potency, longer duration of action. Okay. So if I see this table, I see that bupivacane's lipid solubility is much higher than our lidocaine, which is 366 of lidocaine, and bupivacaine it is 3420. Much higher lipid solubility. Okay. So the potency of the bupivacaine should be very high compared to lidocaine. Definitely, the potency of bupivacaine is high compared to potency of lidocaine, but it is not that higher as we can see by the lipid solubility. So it's not only the lipid solubility on which would influence the potency. There are other things which can also influence the potency. So what are the other things which can affect the potency? See, if it is more lipid soluble, when you are depositing the drug can get more sequestrated in adipose tissue. It can get lost in the adipose tissue. Then it depends upon the distribution of the drug according to the vasodilatation, the regional distribution of the drug, how the drug is distributed. And then they say that you don't need entirely to depend upon the lipid solubility, right, for the potency and for the passage of the drug, right, because there are cation channels through which even the cationed local anesthetic can pass through the membrane of the nerve fiber and reach the intracellular zone. You are getting my point? So it is not entirely on the lipid solubility on which the potency depends. There are other factors like being highly lipid soluble, more sequestrated in the adipose tissue, so more is lost. Local anesthetic potency also depends upon the vasodilatation and the regional distribution of the drug. It also depends upon, they also says there are cation channel for entry of the local anesthetic. So you don't need the only lipid solubility as the way for entering the drug in the intracellular part and binding to the to the sodium channel. So other factors are also, but definitely the more lipid soluble, more potent the agent. Okay. Now one more thing which we need to know, protein binding, right? Why? We can see bupivacaine is highly protein binded. Okay, more protein binded. Why we need to know about protein binding? Because there are a number of clinical conditions in which the serum protein level is less, then the unbinded drug would be more, and there would be risk of more toxicity. So we have to know about this also, that these drugs are highly protein bound, they have a high percent protein binding. So in case of deficiency of plasma protein, free drug would be more available and more risk of systemic toxicity would be there, right? Okay, so now let us see I told you, more the lipid soluble, more the potency. And if you can see, the lipid solubility of bupivacaine is very high. But if I compare the potency of the bupivacaine in different, let's say, regional anesthesia. So B is for bupivacaine, LB is for levobupivacaine, and R is for ropivacaine. B is for bupivacaine, LB is for levobupivacaine, and R is for ropivacaine. And I am comparing it with L, that is lignocaine. Okay. If I consider peripheral nerve block, right? If lignocaine has potency of 1 for peripheral nerve block, levobupiva and ropiva has 3.6, 3 times the potency of lignocaine. For spinal anesthesia, if ligno has potency of 1, levobupiva has potency of 9.6. With ropiva, they have not tested it. So with bupiva and levobupiva, it is potency of 9.6, 9 times higher. And for epidural anesthesia, if the potency of ligno is 1, 4 times the potency of bupiva, levobupiva and ropiva. Just remember this. Okay. So yeah, potency of bupivacaine and its congener, levobupiva and ropiva, is much higher than lignocaine. We'll talk about bupivacaine and its congener more. Okay. So whenever we give these drugs, this is the list of local anesthetic as you can see, and we use it for regional anesthesia. So number of times we add some additives in it when we give it for the regional block. So what are the additives which we can add, and what would be the benefit of the additive? One of the most important additive which we add is epinephrine or adrenaline. Okay. Now why do we add this? Now let's say this is the nerve fiber we want to block, right? This is the nerve fiber we want to block, and we have deposited local anesthetic around it, right? We have deposited local anesthetic around it. Now this nerve fiber is definitely surrounded by the blood vessel. Now local anesthetic has an inherent property of vasodilatation. They dilate the blood vessels. Okay, so when they will do this inherent property of vasodilatation, the local anesthetic will get absorbed more and more systemically. More and more systemically absorbed, more will be taken away from the nerve fiber we want to block, and more getting systemically absorbed, more would be the risk of toxicity. More would be the risk of systemic toxicity, right? We want the local anesthetic to remain here and not to get systemically absorbed. So if adrenaline is added, it will cause vasoconstriction. It will cause vasoconstriction, and it will decrease the systemic absorption of local anesthetic. So what would be the benefit of adding adrenaline? And adrenaline will cause vasoconstriction, right? It would decrease the systemic absorption, right? It will make the block better, more and more drug available. So it will make the block fast and prolonged duration. Duration would be increased, and quality of the block would be better. Quality of block better, right? So addition of adrenaline would give these benefit. Apart from that, this adrenaline can block alpha 1, beta 1 and alpha 2, all the three adrenergic receptor. And alpha 2 adrenergic receptor has shown some, let's say, it has also shown some benefit in the pain pathway. It has a role in let's say, in pain pathway. So adrenaline is agonist to the alpha 2 receptor, and this would synergistically help in analgesia provided by the local anesthetic whenever we are depositing it near the nerve fiber. So synergistic effect of adrenaline is also seen. So adrenaline will also act as synergist for providing analgesia, Okay. Now just remember one thing. Whenever you are putting this adrenaline along with your local anesthetic as an additive, you just have to be careful for one thing. First, that the patient will definitely complain pain, because adrenaline being a vasoconstrictor, it will cause constriction and little bit release of the inflammatory mediator at the site. So pain at the site of injection would be one complaint of patient. And second, you have to be careful that whenever there are end artery, wherever you are putting the block, and if there is end artery, right, end artery, that is, there is no anastomosis system, then you should not use this combination, because the vasoconstriction of this end artery, there would be a vasoconstriction, and the area supplied by that end artery will get affected. Ischemia and gangrene can happen. So end artery sites, this combination is contraindicated. This combination should not be used. Okay. So remember, it's a very good additive. It makes the block faster. It produces a better quality block, increases the duration, it decreases the risk of systemic toxicity, right? It gives us, plus it acts as some synergistic in controlling pain also. So it is a very good additive, but you have to be careful for choosing the site. It should not have an end artery. And with adrenaline added to local anesthetic, the maximum safest level of local anesthetic which we use for a block becomes higher, it increases. So I've just given a list for two main local anesthetic which we use, lidocaine and your bupivacaine. Lidocaine and bupivacaine. If lidocaine I am using alone for a block, maximum safest limit is 300 milligram. And if I am using it with adrenaline, right, with adrenaline, it is 500 milligram, right? We can give more because adrenaline would decrease the systemic toxicity and risk of it would decrease the systemic toxicity by lesser systemic absorption. So risk of systemic toxicity would be less, more drug can be given. Bupivacaine, maximum safest limit alone is 175 and with adrenaline it is 225. So with adrenaline we can give more of the local anesthetic for the block, right? It has increased the safety margin. Remember, surgeons, whenever they give a block for any of procedure, ophthalmic surgeon, ophthalmologist, or let's say dentist, they always mix adrenaline. Why? To increase the safety. Their main concern is safety and definitely the denser block they get. Okay. Now another additive which we can add, which is historical nowadays. I talked that this is the nerve fiber I want to block, right? So we deposit local anesthetic here, and local anesthetic according to its pKa gets dissociated, right, and remains undissociated, right, in an undissociated form. Dissociated means local anesthetic cationated, and undissociated local anesthetic, like this only. And this undissociated can only penetrate the membrane and can block the sodium channel, right? So if we alkalinize the area by mixing sodium bicarbonate with the local anesthetic, right? Especially with like bupivacaine and all. Bupivacaine, we have seen what is the pKa of bupivacaine. It's 8.1. So if I add sodium bicarbonate at the site where I am putting the bupivacaine, the site will become alkaline, and what will happen? Less ionization and more drug would there be for diffusion and blockage. Onset can become fast. But again I am saying this theory is little bit getting challenged nowadays, that we have proton channels, we have protonated channels through which even the protonated local anesthetic can pass into the intracellular part. So addition of or alkalinization of local anesthetic for a block would not give us much benefit. And studies have shown it is giving only a fast onset of 5 minutes faster onset. It is just giving 5 minutes faster onset. So no use of alkalinization. So this is becoming obsolete. This is obsolete. This is obsolete. Nowadays not preferred. Nowadays not preferred to alkaline the local anesthetic solution. Now next, very important, opioids. We add for our spinal, epidural, fentanyl, morphine as the opioid. The opioid have central and peripheral mechanism for producing analgesia. Opioids have central and peripheral mechanisms of analgesic action. Analgesic action, right? It is added, mostly it is added to central neuraxial blockade, that is spinal and epidural, to central neuraxial blockade for synergistic analgesia. They both synergistically provide analgesia. For synergistic analgesia, right? What is the site of action? Primarily by attenuating the C fiber nociception. Opioids primarily act by attenuating C fiber nociception. C fiber nociception. Got my point? Okay. So this is the role of opioids. Very commonly we add it in, let's say, central neuraxial blockade for spinal and epidural. Peripheral, not much popular for peripheral nerve blocks, but for central neuraxial blockade, very commonly we are adding. opioids. Okay. Then the other one is our alpha 2 adrenergic agonists. So clonidine and dexmedetomidine, right? Clonidine and dexmedetomidine, they produce analgesia when we add them with local anesthetic as via supraspinal and spinal adrenergic receptors, via supraspinal and spinal adrenergic receptor. They are also producing synergistic effect, producing a better quality of analgesia. So synergistic effect. One more thing I want to tell you, alpha 2 adrenergic agonist has major role, right? They have a major role in producing analgesia by two mechanisms. One, by producing analgesia via supraspinal and spinal adrenergic receptor, and second, being a adrenergic agonist, they can also cause vasoconstriction. So vasoconstriction would decrease the systemic absorption and would make the local anesthetic remain more at the nerve fiber. So what adrenaline was giving the benefit, even alpha 2 adrenergic agonists are giving the same benefit. Okay. Now steroids. Steroids again has a very major role. You know, steroids when added to peripheral nerve blocks, it has shown that the duration of analgesia would increase by 50%. What original duration of analgesia would be with that particular local anesthetic. With the alpha 2 adrenergic agonist, they say that duration of analgesia increases by 2 to 6 hours, right? 2 to 6 hours. Okay. And with steroids added to peripheral nerve block can increase the duration by 50%. Okay, got it? So this steroid is a very, let's say, useful additive, and for chronic pain management, steroids have from long time it is being used, right? And as an additive for our peripheral nerve block also, it is being used from a very long time. Okay, now we have one more preparation available of local anesthetic, not available in India, liposomal local anesthetic. Liposomal local anesthetic, right? What is this liposomal local anesthetic? Now this is a liposomal preparation of local anesthetic from which the local anesthetic is present in encapsulated liposome, and like your liposomal amphotericin, etc., and slow and on single administration, slow and continuous release of local anesthetic happens, right? So sustained release of encapsulated local anesthetic. Mostly it is for bupivacaine available, local anesthetic. After single administration. Got it? This is liposomal local anesthetic. Got it? Fine. So these are the additive which is added to local anesthetic. Now let us talk about the pharmacokinetic. So we discussed about the physiochemical properties, we discussed about the additives which we can add with local anesthetic. Now let us talk about pharmacokinetic. What do I mean by pharmacokinetic? Now pharmacokinetic, see, this is the nerve fiber I want to block and I deposited local anesthetic here, right? Now what does the pharmacokinetic of any drug means? What does body do to the drug? Okay. So what drug does to the body? It blocks the sodium channel and stops the impulse transmission. What body does to the drug? Now when I deposit local anesthetic around the nerve fiber, it can get absorbed in the surrounding blood vessels and then the body will start acting on the drug. So remember, the plasma concentration of local anesthetic depends upon three things. Okay? Plasma concentration depends upon three factors. Number one, systemic absorption. Number two, tissue distribution, how it is distributed in tissue distribution. And number three, elimination. Okay, now let us talk about first the systemic absorption of local anesthetic. Systemic absorption. Whenever we put the local anesthetic locally near the nerve fiber, rate and the extent it will get systemically absorbed depends upon few very important factors, which we always have to keep in mind for the safe use of the local anesthetic. Why? Because if it will get systemically absorbed, then it will get distributed mostly to those tissues which are highly perfused. It will get distributed more to the highly perfused tissues like your CNS, your CVS, and these are the organs which are worst affected by the toxicity of local anesthetic. So what are the things on which it depends? The systemic absorption. So the rate and amount of systemic absorption. Systemic absorption depends on number one, site of injection, where you are depositing local anesthetic. Site of injection. More the vascular site, more would be the risk of systemic absorption. Second, it will depend upon the dose. More the amount, more would be the systemic absorption. Then third, it would depend upon the drug pharmacokinetics. What is the drug you are putting? Drug pharmacokinetic, right? Drug pharmacokinetic. And fourth, it would depend upon the addition. If I have added any vasodilator, addition of vasodilator. If a vasodilator is added, then it will cause more systemic absorption. So just see, site of injection. If the site where I am putting the block, the site is very vascular, the risk of systemic absorption would be high. Now we put regional anesthesia, we give regional anesthesia at variety of places, right? And for every time for producing regional anesthesia, we have to put local anesthetic. Now sites where we put local anesthetic is different, their vascularity would also be different. If I am putting local anesthetic for intercostal nerve block, intercostal artery and vein is very near, the risk of systemic absorption is very high. Caudal area is again very vascular, risk of systemic absorption is high, so we have to be careful. Then lumbar epidural, right? So there is a sequence which we have to remember. So remember, for site of injection, intercostal nerve block, risk of systemic absorption highest, followed by caudal, followed by lumbar epidural, followed by brachial plexus, followed by femoral, followed by sciatic. So this is the sequence of systemic absorption. Highest in intercostal, right? Then caudal, then lumbar epidural, then brachial plexus, femoral, sciatic. Then the next thing it depends upon is your dose, the dose of local anesthetic. More the dose, more the systemic absorption. I haven't mentioned spinal anesthesia here. When I will discuss with you central neuraxial blockade, I will tell you the volume required for spinal anesthesia. So many of you must have given spinal. For volume required for spinal anesthesia is very minimal, 2 ml, 3 ml. That would never cause systemic toxicity. So dose is a very important factor. More the dose, more the risk of systemic toxicity. So if I just make a graph, see, if I am making a graph, right, if I am increasing the dose, more would go in the systemic circulation. So if I am increasing the dose, the systemic present in the systemic circulation, it would increase if with increase in dose. Okay. Then drug pharmacokinetic. More the lipid soluble, less would be the systemic absorption. So for bupivacaine, the systemic absorption would be less compared to lidocaine. Okay, so more the lipid soluble, less would be the systemic absorption. And then obviously addition of vasodilator would always make the risk of systemic absorption more. Okay, so once it is systemically absorbed, now what will happen? If it is in blood, it will get distributed. So now it will get distributed. So how it is getting distributed, right? Now it depends upon from plasma, it depends upon the perfusion of the organs. The organs which are more perfused, more risk of local anesthetic going into that organ. So distribution depends upon, it depends upon the vascularity, right? CNS, CVS, right? Liver, kidney, these are vessel-rich organs. They are vessel-rich organs. So whenever we will give it, the drugs get systemically absorbed, they will go to the vessel-rich organs more. And guys, these are the organs with a high risk of toxicity. These are the organs where the local anesthetic, if it goes, it will cause the toxicity which can be life-threatening, which we will further discuss. Okay, so we have to be very careful in giving local anesthetic, right? We have to see that we should not cross the maximum safest limit. If possible, add adrenaline so that the systemic absorption is less systemic absorption, less it would be distributed. Then we have to always be careful about the let's say clinical comorbidity of the patient, conditions in which the clearance of the drug would be less, right? Because more drug remaining in plasma, more will go to the organs where the risk of toxicity would be high and the things can go out of hand. Okay, so after distribution, the drug, how it goes out of the body? By elimination or metabolism. Elimination or metabolism. Now guys, elimination or metabolism, I have already discussed. For ester local anesthetic, the metabolism is by plasma choline esterase. It is metabolized by plasma choline esterase. Okay, and for amide local anesthetic, the metabolism is by liver, hepatic co-carboxylase. Okay, so hepatic co-carboxylase, it is responsible for the elimination of amide local anesthetic. And even for cocaine, which I have already told you. Now cocaine, right, was the first natural local anesthetic. It was ester, but it was metabolized by liver, right? Okay, so this is how they are eliminated from the body. Now there are some conditions in which this elimination would also be affected. It will become less or it will get affected. So in that condition, the serum from blood, it will not get cleared. The clearance will be slow. Again, the risk of toxicity would increase. So there are few facts about the clinical about these pharmacokinetic property which we have to keep in mind when we are using local anesthetic for a block. So let us talk about some points about clinical pharmacokinetic. Whatever we have discussed in pharmacokinetic, what is the clinical implication of these properties? Number one, there is increased systemic plasma level of local anesthetic in extremes of ages due to decreased clearance and increased absorption. So, increased risk of systemic plasma level of LA of local anesthetic in very young and elderly, right, owing to decreased clearance and increased absorption. So in extreme of age, if you are giving a block to elderly or to a neonate or an infant, the total volume of the drug which you are using should be less. Second thing in clinical Now, male and female, there is no difference. So, no effect of gender is defined. So, effect of gender not defined. Then, pregnancy, again you have to give less dose. Why? Because of the decreased clearance of local anesthetic. So, in pregnancy, decreased clearance. So, less dose. In liver dysfunction and in heart dysfunction, cardiac comorbidity, again the clearance is less, so dose has to be reduced. So, hepatic and cardiac dysfunction, decrease clearance, so less dose. Renal dysfunction, no effect. Renal dysfunction, no effect, right? In shock, if the patient is in shock and you have to give the regional block, remember, in shock there is a preferential perfusion of the vital organ, CNS, CVS. So whatever drug would be systemically absorbed, it will go and block the sodium channel of brain and heart. So risk of systemic toxicity would increase. So in shock, decrease dose. Why? Decrease dose because of the increased risk of systemic toxicity. So remember this, that these are the conditions in which we have to alter the dose. Remember that in renal dysfunction, no effect. So no dose alteration. Gender, no difference. So no dose alteration according to gender. Extremes of age, less dose. Pregnancy, less dose. Shock, less dose. Liver dysfunction, less dose. Cardiac dysfunction, less dose. Okay, keep it in mind. Okay.